Okay, Bismillahirrahmanirrahim. This is a new topic, opioid analgesics and their antagonists. Now, opioids can also be pronounced as opioids in American terminology, but usually we spell it or we call it as opioids, we pronounce as opioids. So these are opioid analgesics. They are different from the NSAIDs that we already has discussed. These NSAIDs, they are non-steroidal anti-inflammatory drugs, and they only produce analgesia. However, opioid analgesics, they are different from NSAIDs because along with analgesic effect, they produce some sedation and sedative effect as well. And you already know what is sedation. Now, morphine, codeine, and piperine, they are actually derived from an opium plant, and this opium plant is more commonly grown and cultivated in Afghanistan, Pakistan, and Thailand. It is a poppy flower, and how we get from it morphine or these codeine or piperine by making an incision within a plant. Now, here is the plant. Now, morphine is naturally occurring substance, and this juice that is taken up, this is the juice coming out from the plant. This is the juice. It is coming up from the unripe seed pods of the opium poppy. This is the poppy plant, and these are the unripe seeds. So from here we get this, the morphine, and this morphine is actually naturally occurring. Now, classification of narcotic analgesics. These are naturally occurring opium alkaloids, as I've shown you here, that they are naturally occurring because they are taken up directly from the plant. And this has been cultivated mostly in Afghanistan, Pakistan, and Thailand. Okay, so naturally occurring opium alkaloids, they are morphine and codeine. Semi-synthetic derivatives of opium alkaloids, they are diamorphine, which we call it heroin, folcodine, hydromorphone, hydrocodone, oxymorphone, oxycodone. These are the semi-synthetic derivatives of opium alkaloids. However, we have some synthetic substitutes as well, and they are known as pethidine and its congeners, means that some of the drugs are derived further from pethidine, or pethidine has got its own substitutes. By just changing the structures, we can get fentanyl, sufentanil, L-fentanyl, remifentanil, diphenoxylate, and loperamide. Similarly, we have methadone and its congeners like methadone and propexifene, and we have morphinone compounds like livorphenol, and then benzomorphin compounds like pentazocine, phenazocine, cyclazocine. Now, what are endogenous opioid peptides? Endogenous means they are naturally present within our bodies, and they are known as endorphins, enkephalines, dynorphins, and nociceptin. So these are acting on different receptors. Like this receptor is known as mu, this is kappa, and this is delta. These signs, they are, now we can pronounce them in a different way because three of them are very different from each other. And now endorphins activate three of these receptors. These are the three basic receptors on which opioids, they act: mu receptor, kappa receptor, and we have delta. Similarly, enkephalines, they activate only two receptors, mu and delta receptors. Dynorphins, they activate mu, kappa, and delta receptors. Nociceptin activates ORL1 receptor. Then there are certain derivatives that are derived from precursor proteins. Now, these derivatives, three of them, they are coming up from some proteins that within our body, and they are naturally present, like pre-pro-opiomelanocortin, then pre-pro-enkephalines, and then we have pre-pro-dynorphine. Now, opioid receptors and what happens on stimulation? What are the effects on their stimulation by opioid agonists? First of all, we classify receptors as mu, kappa, and delta, as I've told you. Now, what are the functions of these receptors on stimulation? We will take them one by one. Like when mu receptors, they are stimulated, they can cause supraspinal and spinal analgesia, sedation, decreased GIT motility, respiratory depression, increased prolactin, and then growth hormone release also increases, inhibit certain neurotransmitters like acetylcholine and dopamine, and they can also cause physical dependence. Now, this is the difference between opioid analgesics and non-steroidal anti-inflammatory drugs, because they produce physical dependence, opioids. However, NSAIDs, they do not produce any type of a physical dependence. Then we have supraspinal and spinal analgesia and sedation by stimulation of kappa receptors. So predominantly, actually, mu receptors, they are the most used receptors by morphine and some drugs related to this group. On stimulation of delta receptors, again, there is supraspinal and spinal analgesia, decreased GIT motility, but increased growth hormone release. However, there is inhibition of release of dopamine. Now, what are the cellular actions of opioids? Cellular action, we can take it as mechanism of action as well, that what they do at the cellular level. Opioid action on a neuron. Now, whenever it acts on a neuron, it acts presynaptically and postsynaptically. There are two nerve terminals, and we already discussed before that whenever how a synapse is made and how the signals they are transmitted through presynaptic nerve terminals, and they reach the postsynaptic neuron. Now, what happens at these stages? Now, in presynaptic nerve terminal, what there is, the cellular action is mainly related to the voltage gated calcium channels. Now here there is inhibition of the calcium channels. So they inhibit release of neurotransmitters, substance P and glutamate. Now one thing, you know it, that glutamate is excitatory neurotransmitter. So whenever, definitely, why we use these drugs? To inhibit excitation. So glutamate is, as it is an excitatory neurotransmitter, so its functions will be inhibited. Now, what happens at the postsynaptic neuron? There is opening of the potassium channels, so there will be potassium efflux. So whenever there is potassium efflux, there will be marked hyperpolarization. So potassium channels, they will be hyperpolarized. Now, here is just a diagram showing that what happens whenever there is a heat, cold, pressure, or a tissue injury. You all know it because whenever we were talking about NSAIDs, the schematic diagram, you remember, it is related to all this phenomena. Whenever there is a heat, cold, any pressure, or a tissue injury, these substances, they are released from the cells, from the cell surface. Bradykinin, 5-hydroxytryptamine, prostaglandins, energy is released along with them. What happens? This is now the periphery. This action happened where? Within periphery. Whenever these substances are released, along with these substances, you see here's mast cell or neutrophils, and this mast cell releases histamine. This is neutrophilic growth factor. It's also being released. So all these factors together, they can go through the afferent nerve fibers within a spinal cord. Here you see the signals, they are received from the efferents, they go to the higher centers, and then the command is given. So now these substances, whenever they are released, you see this is substance P. Whenever it is released, it has its effects on blood vessels. Similarly, these cell bodies, some of the cell bodies are involved here in this phenomena. And here also you can see that this is a loop. A loop means that this phenomena is taking place on one hand, it's going to the spinal cord. On the other hand, it can go again. This, if we forget about this for a while, so all this phenomena like substance P release, acting upon the mast cell or neutrophils, histamine is released, further potentiating effect of histamine by the neutrophilic growth factors. All these factors, they produce nociception. Actually, what is this nociception? It is a perception of this stimulus through all this phenomena to the higher centers of the brain through via spinal cord. Now here it's the same. Whenever a pain stimulus arises, it comes through periphery. MOR is actually a mu receptors. So these receptors, what happens? We have mu, we have kappa, and we have delta receptors. As I mentioned here, on stimulation, what happens? Yes, supraspinal spinal analgesia, sedation, decreased GI motility, respiratory depression, prolactin, growth hormone release, but there's inhibition of some neurotransmitters, and and it has got physical dependence as well. So here, this schematic diagram, it shows the pain stimulus within periphery. Here are the mu receptors. MOR stands for the mu receptors. You see the signal is through the primary afferent nerve fiber. However, there is inhibition of the phenomena here through these drugs. So what happens? There is no stimulation. Along with this, there's potassium efflux. Now here is the glutamate and neuropeptides. Here you can see that there is inhibition, so stimulation is inhibited. So less release of the neurotransmitter at the side. This is the synaptic cleft, and this is the post-synaptic neuron, or we can call it secondary afferent neuron. This part is the dorsal horn of the spinal cord. Along with this, you can see calcium influx, but this calcium influx is inhibited. This negative sign shows there is inhibition of the calcium influx. So what happens through all this phenomena? This stimulation of the neurotransmitters like glutamate, substance P, it is blocked, and hence depression occurs. So some neuropeptides receptors also present. There is NK1 stands for a neuropeptide receptor. So this all phenomena is actually a mechanism of action, general mechanism of action of these drugs through periphery. So this is the pain stimulus through the periphery, action on the mu receptors. This is the primary afferent nerve fiber, and this is the dorsal horn of the spinal cord over here. This is the synaptic cleft from where the neurotransmitters are being released, but here you see it is blocked because of the efflux of the potassium ions, inhibition of the influx of the calcium ions, and here you can see the actions are actually less marked because of the inhibitory effects. So this is a secondary afferent neuron having some of the receptors related to this neuron, but here the positive effect is, this is again a mu receptor over here, but whenever it will be stimulated, again it shows the potassium efflux. So hyperpolarization is important phenomena, and calcium influx is also important phenomena for the basic mechanism of action of these opioid analgesics at the cellular level. However, but whenever there is calcium influx, but this is inhibited. Calcium is there, but its actions are inhibited. So this can cause less stimulation, less release of the excitatory neurotransmitters, and so less effect of the stimulation. So there will be depressive effect or sedative effect will be produced along with the analgesia. It's again the same diagram, and here stimulation is over GABA receptors. So this we already discussed before in signaling mechanisms. Here you see opioid receptors. Basically this is a mu receptor. MOR stands for mu receptor, and there is a negative effect. So there is GABA receptor. These are inhibitory receptors. So descending inhibitory neurons, so action potential is reduced. This is a negative effect. So what are the pharmacological effects? On CNS, we have analgesia, euphoria, means sense of well-beingness. Patient feels that everything is okay, he's happy. Sedation, convulsions, respiratory depression, depression of cuff reflex, there is nausea and vomiting. Meiosis is constriction of the pupil, truncal rigidity, and temperature. Peripheral effects are mainly on the CVS, cardiovascular system, GIT, biliary tract, kidneys, or renal, and some are miscellaneous. What are the therapeutic uses for these drugs? They can cause relief of severe pain. Left ventricular failure can occur with massive pulmonary edema. They can be used for pre-anesthetic medication along with the other drugs. And terminal care of cancer patients. Terminal care, when the cancer patients are in stage 3 or in stage 4, then we can use these drugs. Also relief of anxiety in frightening conditions. Then antitussive, they can even depress the cuff reflex. They can control acute restlessness, and also they can use in anesthesia. What are the adverse effects? Respiratory depression, because you all know they depress the function of or they inhibit the stimulation of the excitatory receptors like excitatory neurotransmitters like glutamate, substance V. Sedation and euphoria, nausea and vomiting, constipation, urinary retention, itching and urticaria, postural hypotension, tolerance and dependence. Opioid agonist and antagonists. Nalbuphine, butorphanol, pentazocine, buprenorphine. These are the opioid agonist and antagonists, both actions. They have both actions. Pentazocine, it can act on the receptor. It is a kappa receptor agonist and weak antagonist or partial agonist at mu receptor. Nalbuphine, so you see they have got mixed actions, mixed agonist and but weak antagonist effect. Nalbuphine is a strong kappa receptor agonist but more potent actions at mu receptors. So it is more antagonist at mu receptor. Butorphanol, kappa receptor agonist and weak partial agonist or antagonist at mu receptor. Now, buprenorphine, kappa receptor antagonist and partial agonist at mu receptor. It slowly dissociates from the receptors, so has got long duration of action. That means it remains bound to the receptor for a long time. It is used for the management of opioid dependence. Now, what are opioid antagonists? Now, these antagonists are only antagonists. They're purely antagonists acting on the opioid receptors, nullifying the effect of the agonists. Now, opioid antagonists, they are used to treat opioid overdose cases, and most are derived from thebaine. This is an alkaloid of opium. And they have got strong binding affinity for the mu receptors. They work by competitive inhibition at the binding sites, and most important and most commonly used is naloxone. However, nowadays we have naltrexone, we have nalmefene as well. Naloxone is the best example of an opioid antagonist. As I told you, this is the most commonly used antagonist for the opioid receptors. It is administered intravenously and it can rapidly produce the withdrawal symptoms associated with opioid addiction. The others, naltrexone and nalmefene, they are like naloxone but have got longer duration of action as compared to naloxone. Naltrexone is also used in the treatment of alcohol addiction. Now, these are some of the very basic differences between the narcotic and non-narcotic analgesics. Narcotic analgesics are these opioids, the ones now we were discussing. However, non-narcotic analgesics are the NSAIDs that we already discussed before, like, aspirin, paracetamol, ibuprofen. So these are some of the differences. I just tabulated them and summarized them for your convenience. Source, heterogeneous synthetic, and the others, they are naturally occurring. Structure, heterogeneous, they have different structures. However, opioids are phenanthrene compounds, basically are made up of benzyl isoquinoline compounds. Type of pain relieved is somatic for NSAIDs. For opioids, it is deep visceral pain. Mechanism of action, that NSAIDs, they inhibit prostaglandin synthesis by inhibiting cyclooxygenase enzyme pathway, you all know, hence inhibit generation of nociception. What is nociception? It is perception of the stimulus like cold, heat, trauma, any stimulus. Then no action on specific receptors. However, opioids, they decrease the nociception input, that is the feeling over the skin, processing and integration whenever they are traveling through the efferent neurons and they are integrating within the brain. Transmission back, they are coming up by the efferent fibers onto the skin, so that becomes perception. And then emotional reaction to the pain, that is withdrawal of the limb, withdrawal of the forearm. So this is the reflex, actually we call it, or someone can scream out. So this is emotional reaction to pain. How this happens? By causing hyperpolarization due to increase in the potassium efflux, decreased release of neurotransmitters, especially excitatory neurotransmitters, and actions on the opioid receptors. So we have mu, kappa, delta, epsilon, and sigma. NSAIDs, they do not depress CNS. However, opioids, they depress CNS. NSAIDs, you all know, they act as analgesic, antipyretic, anti-inflammatory, no spasmogenic effect on the GI smooth muscles. However, opioids, they act only as analgesic, also produce sedation and hypnosis, no antipyretic and anti-inflammatory effects. Morphine alkaloids have got marked spasmogenic effect, mainly on GIT smooth muscles. NSAIDs, they do not produce dependence. However, opioids, they produce dependence. They do not produce withdrawal syndrome, NSAIDs. However, opioids, they produce the withdrawal syndrome. Side effects for NSAIDs mainly due to inhibition of prostaglandin synthesis in various systems of the body, like respiratory, genitourinary tract, renal, GIT, etc. Opioids, they have got mainly adverse effects related to the CNS, and they can cause CNS depression. More serious is due to depression of the respiratory center. Thank you so much for listening and your attention.